Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome everyone. In this episode, we are going to review the basics of infertility, the causes, the investigations, and the treatment options. Each of these topics will be reviewed in a lot more detail in later episodes, but I hope to develop a foundation in this episode, a bird's eye view of fertility and infertility. Infertility is traditionally defined as the inability to conceive after 12 months of regular, unprotected intercourse in people in a heterosexual relationship. However, because of the significant impact of age of the ovaries and eggs on fertility, it is recommended that individuals with ovaries who are under 35 years of age seek fertility testing and treatment after 12 months of trying to conceive. Yet individuals with ovaries who are over 35 years of age seek evaluation after 6 months of trying to conceive. Some other reasons for seeking fertility testing sooner would include 1. Irregular menstrual cycles, in which case you should see a fertility specialist right away once you are ready to try and conceive. 2. Age 40 years or older for those with ovaries, in which case you should probably consider seeing a fertility specialist after 3 to 4 months of trying to conceive. 3. Known sperm factor fertility, in which case you should consider seeing a fertility specialist sooner, depending on the issue and the severity. And 4. The need for donor sperm or donor eggs, which means you likely need a fertility specialist to assist you right away. In Canada and worldwide, 1 in 6 couples or individuals face difficulties conceiving and are said to have infertility. Primary infertility means you have never been pregnant before and are having difficulty conceiving, whereas secondary infertility means you have had at least 1 pregnancy in the past, whether or not it resulted in a live birth, and are now having difficulty conceiving. The causes of infertility can be divided or categorized in a variety of ways. Let's look closely at one of these ways. This is how I like to break things down to understand the main causes of infertility. Infertility may arise from an issue with the uterus, tubes, or ovaries, essentially the internal reproductive organs, or from an issue with the penis or testicles, the external reproductive organs, or a combination of factors. An issue with the uterus, tubes, or ovaries, sometimes called female factor infertility, is said to make up approximately 30% of cases of infertility. An issue with the penis or testicles, sometimes called male factor infertility, is said to make up approximately 30% of cases. Combination infertility makes up approximately 25% of cases, and unexplained infertility, where a cause has not yet been identified, makes up approximately 15% of cases. These percentages may vary slightly based on the source you look up, but this gives you a general sense of the breakdown. I think it's important to highlight this division of causes, as many patients and people in general still think that fertility challenges are mostly a woman's issue. I say this in quotes that you can't actually see because it's what I hear often in the office and in life, when the reality is that a large percentage is caused by sperm factor, and another large number of cases are combination infertility involving multiple factors. Let's break these down a little more to get a deeper understanding of the actual causes of fertility challenges. Let's start with issues involving the internal reproductive organs, the uterus, tubes, and ovaries. These can be broken down into ovulatory disorders and ovarian factors, uterine and cervical factors, tubal factors, and endocrine or hormonal factors. Disorders of the ovaries and ovulation include polycystic ovarian syndrome, or PCOS, diminished or low ovarian reserve, and premature ovarian insufficiency, or POI, which was previously called premature ovarian failure, or POF. Disorders of the cervix and uterus include uterine malformations, such as a uterine septum, lesions in the uterus, such as a polyp or fibroids, and scar tissue or adhesions within the uterine cavity. Tubal disorders include blocked or damaged fallopian tubes, one or both, which can result from untreated sexually transmitted infections like gonorrhea or chlamydia, pelvic or abdominal surgery like a ruptured appendix, or endometriosis. Endocrine factors that may affect fertility are due to an imbalance of the reproductive hormones. These involve the hormone axis between the hypothalamus and the pituitary gland in the brain and the ovaries. Some common hormones involved are follicle-stimulating hormone, or FSH, luteinizing hormone, or LH, estrogen, progesterone, thyroid hormone, and prolactin. This is just a small list of the specific causes that can play a role, as a complete list would be way too long to review here. But I would say that these are the causes we more commonly hear about. Issues involving the external reproductive organs, the penis and the testicles, can be broken down into endocrine or hormonal factors, testicular factors, and reproductive tract factors. Endocrine factors related to the external reproductive organs involve the hormone axis between the hypothalamus and pituitary gland in the brain and the testicles. Common hormones involved include FSH, LH, and testosterone, which is key to sperm production. Disorders of the testicles involve failure to produce sperm in adequate amounts or at all. Various causes may lead to this, including varicoceles, testicular lesions, chemotherapy, and genetic causes such as Klinefelter syndrome. Disorders of the reproductive tract include obstructions of the tract, preventing sperm from traveling from the testicles, where it's produced, to the ejaculate. Causes for such obstructions may include hernia repairs, absence of the vas deferens, ejaculatory duct abnormalities, vasectomy, genital tract infections such as gonorrhea or chlamydia, and genetic conditions such as cystic fibrosis. Lifestyle factors also play a role in fertility, as they may affect both egg and sperm quality. This includes factors such as smoking cigarettes, excessive alcohol intake, recreational drug use, and exposure to environmental toxins. These are not to be taken lightly. They play a key role in reproductive health, and they are modifiable, meaning individuals have the ability to make changes to these factors, unlike many of the medical conditions affecting fertility. A complete and thorough medical and lifestyle history are key to identifying the relevant factors when seeing an individual or couple to discuss their fertility. With respect to the internal reproductive organs, for people with ovaries, a gynecologic history is very important. When did you start having periods? Is your cycle regular or not? Is your period heavy? Do you ever experience bleeding between cycles? Do you experience significant pain with your periods? Have you ever noticed milk or discharge from your breasts? These are just some of the relevant questions you may be asked. Another key question is whether you have had any recent changes in your cycles, significantly longer or shorter, heavier or lighter. All of this information can help guide the differential on factors affecting your fertility. If you have had previous pregnancies, your obstetrical history is also vital. How long did you take to conceive? Did you need any fertility testing and treatment then? Whether or not the pregnancy resulted in a live birth, did you require any surgery on your uterus? And if you had a delivery, were there any complications, such as an infection? Individual medical and surgical history is also important to discuss. Certain conditions may affect fertility itself. For example, a ruptured appendix or other abdominal surgery can impact the fallopian tubes if scar tissue develops around them and causes a blockage. Other conditions are important for treatment planning, as fertility treatment involves various hormones. So, for example, a history of a blood clot or a clotting disorder is important to be aware of before using hormonal medications and may require modification of a treatment protocol. Family history is also an important component of your history, as it may reveal relevant medical factors or infertility risk factors that need to be considered. With respect to the external reproductive organs for people with testicles and sperm, information around injury, infection, or surgery to the groin are very relevant. This does not necessarily include your common kick to the groin in gym class, but something that required medical attention or treatment. For people who come to the office and have been trying to conceive on their own, it's also important to discuss what that means to them. Are they having intercourse, or do they have any issues around intercourse, like issues with erections or ejaculation, pain with intercourse or vaginal penetration? Are they timing intercourse, and if so, how? Using an app or an ovulation predictor kit, or cycle length, or perhaps cervical mucus? With what frequency are they having intercourse? Believe it or not, there is such a thing as too frequent intercourse when trying to conceive, and we will dive into this shortly. On the flip side, I hear from many patients who tell me they are trying to conceive, yet having intercourse maybe once a month, so too infrequently to give a good chance at pregnancy. Now that we have reviewed the definition of infertility, many of the causes of infertility, and the relevant history that we need to assess an individual or couple seeking a fertility assessment, let's talk about investigations. What are some of the basic tests that are needed to assess fertility? Let's start with assessing the uterus, tubes, and ovaries. To assess the ovaries, there is a group of tests called ovarian reserve tests. This includes blood work and ultrasound to get a sense of egg quantity and responsiveness of the ovaries to fertility medications. These include a day 3 follicle stimulating hormone level, or FSH level, which is a blood test, a day 3 antral follicle count, which is an ultrasound test, and an anti-Müllerian hormone level, or AMH level, which is also a blood test. To assess the uterus and tubes, you need a pelvic ultrasound, and then either a hysterosalpingogram, which is an X-ray test, or a sonohystogram, which is an ultrasound test. To assess the testicles and penis, there needs to be an assessment of the sperm, as it reflects testicular function and the integrity of the reproductive tract. For this, you need to complete a semen analysis. This looks at the volume of the ejaculate, the concentration of sperm production, the motility of the sperm, and the morphology of the sperm, which is the size and shape of the sperm. Additional blood work is also often done as part of an initial fertility workup to assess endocrine factors or other hormones, like thyroid, prolactin, and blood sugar. So as we have learned, there is a lot to discuss and many tests to do once you see a fertility specialist. Before you invest time, emotion, and money into fertility treatment, your physician will want to look into factors that may be playing a role in your individual case. But what I often get asked from friends, colleagues, even patients that I'm seeing for a fertility assessment in consideration of egg freezing is, what can I do to improve my chances of pregnancy when I first start trying to conceive, before ever seeing a doctor? I think this is a great question. There certainly are things one can do to optimize fertility. Let's discuss 3 of them. 1. Lifestyle factors, important for both egg and sperm quality. Smoking cigarettes is the first factor to stop. Recreational drug use is another factor to stop. Marijuana is the one I most commonly hear about when I ask about drug use, but this does include all recreational drugs, as they are all toxins for the sperm and the eggs. More recently, people have been shifting from smoking cigarettes to vaping, and from smoking marijuana to consuming it in other forms. Data is more limited on these newer ways of taking in these toxins, but they are toxins nonetheless. So my advice is to eliminate all intake. Alcohol is the last factor to discuss. Once again, alcohol has been found to have a negative impact on sperm and egg quality, so I want people to limit their intake. Ideally, you would cut this out completely, but if not, I would say no more than a few drinks per week. And in people with ovaries, no alcohol after ovulation and intercourse. 2. The fertility window. It is important to understand the ideal fertility window and frequency of intercourse during this window in order to optimize your chances of pregnancy. For those with regular menstrual cycles, ovulation occurs approximately 14 days before your next period. So for a 28-day cycle, this would be around day 14. But you don't always know exactly when your next period is coming, so I usually advise patients to start having timed intercourse 3 to 4 days before this, so day 10 or 11 in this case, for about a week. You can adjust this if you are having a slightly shorter or longer cycle. Simply count 14 days prior to your average cycle length and then start having intercourse 3 to 4 days before this for the next week. In terms of frequency of intercourse during this fertile window, I usually advise patients to have intercourse every other day during the fertile window. Sperm will stay in the cervix for a few days, so you do not need to have intercourse daily or more than one time a day. And having intercourse every other day allows time for sperm to reaccumulate in the ejaculate. This is how you calculate your fertile window based on cycle length, but there are other ways to time intercourse as well. You can use an app to track your cycles, and it will then calculate your fertile window for you based on the length of your last few cycles. Alternatively, you can use an ovulation predictor kit, where you pee on a stick daily leading up to your expected ovulation, and the stick picks up the luteinizing hormone in your urine to indicate that ovulation is approaching. This is based on the fact that luteinizing hormone, or LH, surges in the urine and blood just prior to ovulation. In this case, I would recommend having intercourse on the day the stick turns positive and the next day. 3. Supplements. This can be a hot topic, as many people are talking about what vitamins and supplements you should be taking. And a quick internet search will give you a long list of things to start taking immediately. A prenatal vitamin is recommended 3 months before trying to conceive. The most important component of a prenatal vitamin is the folic acid, which can be taken on its own or as part of a prenatal vitamin. You want at least 0.4 milligrams of folic acid unless you have risk factors for a neural tube defect, in which case you want 5 milligrams of folic acid daily. High-risk individuals are those who have had a previous pregnancy affected by a neural tube defect, or have a neural tube defect themselves, or have a first-degree relative with a neural tube defect. Aside from folic acid or a prenatal vitamin, vitamin D is another important vitamin for fertility. Depending on where you live in the world, you may be deficient in vitamin D. This is quite common here in Canada. Many people will start taking vitamin D supplements on their own, and this is okay, but you can also have your primary care provider test your level so you know where you are at. A well-balanced diet with whole foods can help ensure you get the vitamins and minerals you need for pregnancy, and a prenatal vitamin can help supplement this. These are the basics of what you need when first trying to conceive. So the last part of this overview of infertility is the treatment. What treatment options are there to help you conceive? Whether you are having difficulty conceiving or whether you need fertility treatment for another reason, like needing donor eggs or donor sperm to help you conceive. I like to divide fertility treatment into 3 paths. 1. Ovulation induction to help people who don't ovulate on their own. This can be done with pills commonly, but also with injections if those pills don't work to help you ovulate. 2. Controlled ovarian stimulation, where those same pills or injections are used to try and mature a few eggs in a cycle, in order to help increase pregnancy rates in people who do ovulate monthly but are not getting pregnant. Both ovulation induction and controlled ovarian stimulation may be combined with timed intercourse or intrauterine insemination, also called IUI. 3. In vitro fertilization, or IVF, where the ovaries are stimulated with injectable medications to produce several eggs, which are then extracted from the body, fertilized with sperm to produce embryos, which are then grown in the lab and then transferred back to the uterus for implantation. All of these treatment options, ovulation induction, controlled ovarian stimulation, and IVF, can be done with a partner sperm or with donor sperm. In addition to these treatment options, technology is ever evolving in the world of fertility, and additional treatment options currently include IVF with pre-implantation genetic testing, donor egg IVF, and using a gestational carrier with IVF. So there you have it, the basics of infertility, the definitions, the causes, the investigations, and the treatment options. There is a lot to discuss and consider with a fertility specialist, many tests to undergo, and a number of treatment options available depending on your specific case. I hope this episode was useful in allowing you to better understand fertility and infertility. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.